You know very well that in 2025 new guidelines on the treatment of multiple myeloma have been published, and our two chairs are two of the leading authors of the paper. So one of the novelty in the treatment of newly diagnosed myeloma patients was the use of quadruplets, both in the transplant and in the non-transplant setting. Quadruplets that include anti-CD38 monoclonal antibody, plus bortezomib, lenalidomide, and dexamethasone. Then, for transplant-eligible patients, transplant is recommended, and thereafter we have also a new standard of care for the maintenance phase, recently approved by EMA, that is the combination of daratumumab and lenalidomide. In the transplant non-eligible setting, after a fixed number of induction cycles with quadruplet, then again we have a continuous therapy with anti-CD38 and lenalidomide. So you see that despite this novelty and more effective therapies in the transplant non-eligible population of patients, still one of the major determinants of the treatment choice at diagnosis is eligibility for transplant. In the guidelines, indeed, transplant is recommended upfront for all patients up to the age of 70. It was 65 in the past, it's 70 now, for several reasons. One is the one that in the trials that led to the approval of the quadruplets, indeed the age cutoff was 70. These patients should be fit with no comorbidities. Why do we have still transplant there? Well, because we have a lot of data that actually came from the past and from the comparison of 3 drug combination with transplant or without transplant that proved a huge advantage in terms of overall survival for patients receiving a consolidation with transplant after effective induction with proteasome inhibitor and immunomodulatory agents compared with patients that just received the novel therapies without transplant. We have to admit that there is no overall survival advantage reported in trials, but the benefit in terms of PFS is huge. What do we know about the era of the quadruplet regimens? We don't have a randomized trial comparing head-to-head quadruplet followed by transplant or quadruplet without transplant. We have, however, large phase 3 trials with a high number of patients enrolled that showed the outcome of patients with, for instance, Dara-VRD followed by transplant or not. This analysis was presented by Peter last year, and this analysis that showed the median projected progression-free survival based on the Perseus data for the Dara-VRD patients that received transplant and Dara-Len maintenance. And the median projected PFS for these patients is 17 years, 17. While looking at the data that come from the Cepheus trial, so Dara-VRD in the non-transplant setting, transplant non-eligible population, the median progression-free survival estimated is 8 years. So we can't compare data in between 2 trials. These are different populations, everything is true, but this huge difference in the median PFS may suggest that the role of transplant plays a role also in the era of quadruplet combinations. If these are the data, what are the questions that are opened? There are several. One is referring mostly on the patient features. There is a gray zone of patients that we all see in our clinics every day, and it is represented by elderly patients, patients that have some comorbidities, frailty or performance status that may affect the treatment choice and for whom we may be not so confident in using high-dose therapy. Then there are other factors that we would like probably to implement in our clinical practice to make the treatment decisions, because we know that there are factors that affect prognosis, the baseline features and also the dynamic risk assessment that is based on response and specifically on measurable residual disease evaluation. So starting on the patient features, there was a trend in recent years, and this is a report from 1995 to 2019, on an increase, progressive increase on the number of patients that received transplant. More importantly, of an increase in the number of patients over the age of 65 that got transplant. Even more important than the number of patients who receive transplant is to see the outcome of these patients. And indeed, going through the years, in more recent years, there is an improvement in the global overall survival for patients receiving transplant that is seen in younger patients, less than 65, but also in the elderly. This is potentially related to better induction, better consolidation, better maintenance, but likely also to an improvement in the supportive care that reduces the treatment-related mortality. And if we look at the 100 cause of mortality, for instance, in patients between 60 and 64 or 65 and 69 years, it is almost the same. This is also because more than the chronological age, we look at the biological age and we look at performance status and comorbidities that affect overall survival and non-relapse mortality. And we generally look also at frailty. There are several frailty scores in hematology and in myeloma. We have in myeloma such a gold standard that is the IMWG frailty score. This score has been applied quite recently in a cohort of real-life patients between the age of 65 and 75. So you can see that frail patients, they have a worse outcome. No one of these patients was candidate to transplant. The outcome of fit or unfrail patients look to be similar. And if you look at the impact of transplant eligibility because of the clinical judgment, patients eligible for transplant did have a better PFS compared with patients non-eligible. And if we look at the unfit group of these patients and the impact of age, this was seen up to the age of 70, but not evident over 70 years of age. So no benefit of transplant in the unfit population of these patients. One last word about frailty. Frailty is dynamic. This is a concept of frailty in the elderly that, to my opinion, can be applied also to the transplant-eligible patients or the gray zone. Why? Because we may have patients that at baseline, they are frail because of the disease, they have a bad performance status, but we apply a highly effective therapy, they respond and the performance status improve. Or on the other hand, we may have patients that they are not frail. You look at them, you see there will be no issue with the toxicity, and then you end up with severe toxicity or comorbidity during induction. That's a sort of stress test that can help you in looking better at the patient. So if we think about the patient selection and how can we use it now in the era of quadruplet, I believe that also according to the guideline, we may have a group of patients that they are younger than 70, they have a good performance status, no significant comorbidities, and they are fit, so they are candidate to high-dose melphalan and autologous transplant. We may have other patients in a sort of gray zone because of the age, because of the performance status, the comorbidities, where the risk-benefit of transplant needs to be carefully evaluated, and the dynamic evaluation can be important. Talking about comorbidities, one comorbidity that always comes up in the treatment of myeloma patients is renal failure, because renal failure is a CRAB symptom of myeloma. And because in different reports, up to 50% of the patients may have some sort of renal failure at diagnosis. According to the guidelines, renal failure is not a contraindication per se to transplant. Transplant can be safe and effective in patients with a stable renal failure, including patients on dialysis that, of course, have to receive a reduced dose of melphalan. Most of the reports on dialysis patients and on the role of transplant come from retrospective data. There are not big trials on this population of patients. This is an analysis quite recent from the EBNT group that evaluated patients still treated mainly with triplets, and that showed a median progression-free survival of 3 years for patients in dialysis receiving transplant, and a 5-year overall survival of about 60%. Factors that impacted on outcome were age, of course, younger they do better, but also response at the time of transplant, which was a good prognostic factor for patients who responded well. And we may think that in the era of quadruplet, it may stay there because we have a higher probability of achieving good responses. Now, how baseline risk factors or dynamic risk factors can help in the treatment choice? So far, the treatment is the same for all, but maybe these factors can help us in the future or in some gray zone. We know that we treat basically most of our patients in the same way, but we may risk, because of different risk factors related to the patients, to undertreat some patients and to overtreat some others. And risk definition in myeloma is extremely complex. We have clinical factors and biological factors. So the role of transplant in high risk is clearly established. It has been established in the era of triplet combinations with randomized trials that show that high-dose melphalan improved the outcome compared with no transplant, because the outcome of patients that did not receive the transplant was particularly poor. In the quadruplet era combination, different reports show that transplant increased the depth of response in the sequential approach. And these are the data coming from the master study that evaluated DARA-KRD induction followed by transplant, and that showed the role of high-dose melphalan in improving the depth of response, particularly for high risk. Thus, I will not talk too much about high risk, but referring simply to transplant, for high risk and very high risk patients, even tandem transplant can be considered according to the new guidelines. This is because randomized studies in the era of triplet show that double transplant improved PFS compared to single transplant, and also data of sub-analysis of quadruplet combinations in the context of single transplant show that maybe this approach is suboptimal for the very high-risk patients that have an inferior outcome if compared with patients with good or intermediate prognosis. And this is the reason why there are trials in the high-risk setting that are implemented double transplant in the context of quadruplets. What do we know about standard risk? In general, what works for high risk works even better in standard risk. No randomized comparison in the era of quadruplet. Here you see the data from the Perseus, DARA-VRD and transplant, and the Cepheus trial, DARA-VRD without transplant. Again, two different populations of patients. Risk factors impact on outcome. The only thing I'd like to say is that the DARA-VRD treated patients receiving transplant and having standard risk disease at present have a median PFS of more than 90%, which is, a 4-year PFS that is more than 90%, which is extremely good. So currently, standard of care is transplant regardless of risk for eligible patients. What about the dynamic risk evaluation, and particularly the MRD evaluation? You know that MRD is one of the most powerful prognostic factors in myeloma, as in other diseases. In myeloma, more than a single MRD time point is the duration of MRD negativity, the sustained MRD negativity, that proved to be able to overcome or at least mitigate the adverse prognostic features related, the adverse prognostic impact related to the baseline features. So what do we know about an early evaluation time point of MRD? Because this is what we need if we want to implement MRD in our treatment algorithm decision for transplant. We know that generally early MRD predicts a better outcome. This is a report from the Spanish group. We have Bruno here. This is a report from our Italian group where we looked at the impact of early MRD versus late MRD on the MRD duration and risk of MRD resurgence. And patients that respond early, they have a better outcome. So this is the rationale also to use MRD to drive treatment decision early, and we have this beautiful trial conducted by the IFM group, which I believe many of you know, that is the MIDAS trial that evaluated MRD after 6 cycles of induction as a dynamic and unique factor to discriminate how to treat the patients thereafter. So patients that achieve MRD negativity, they were randomized to either single transplant or consolidation with quadruplet combination. They are good prognosis, dynamic good prognosis patients. Patients that did not achieve MRD, considered dynamically as high risk, they were randomized to more intensive approach, double transplant or single transplant. So far, the data that we have refers just to this time point, the MRD evaluation after consolidation of transplant. And the conclusion of the trial so far are that in patients that are MRD negative after induction, single transplant or consolidation did not change the rate of MRD negativity. On the other hand, for patients that are MRD positive, double transplant did not improve the rate of MRD negativity compared to single transplant. The main limitation so far is that we are looking at a single MRD time point again. We don't have yet, because of follow-up, the data on sustained MRD negativity and on PFS. So we have to wait a bit more to understand if we really can change our treatment algorithm according to the early MRD evaluation. There is one last point that makes the use of MRD as an early time point more complex, and that comes from the result of the trial. So overall, about 60% of the patients with this highly effective induction achieved MRD negativity. But if we look deep into the different biological groups, the rate of MRD negativity is really different in different subsets. So somehow expectedly, high-risk patients, they have a lower rate of MRD negativity, so they go to the path of treatment more intensive, which can be absolutely good and absolutely reasonable. But also some other patients with not necessarily high-risk disease, for instance, patients with translocation 11-14, they have a low rate of MRD negativity. This may be because they are less responsive, or this may be because there is a different kinetics of the elimination of the disease in different biological groups. And this could be the case for 11-14, as shown also by our group or by other groups. They respond to treatment, they not necessarily have the bad prognosis, they don't have the bad prognosis of high-risk patients, but they clear the disease more slowly. So this makes the discussion on the use of MRD and on the optimal time point for different groups of patients more complex, not only for high risk, but potentially for other groups. So to conclude, transplant upfront currently is the standard of care for transplant-eligible patients up to 70 years, no comorbidities, fit. High rate of response, high PFS also for standard risk patients. A transplant can still be considered also in the gray zone if we apply all the results that we have seen in the past for the same reasons in the actual context, also for some patients in the gray zone. For these patients, maybe we can start to have some help in our treatment decision where we are in doubt if we put together also some baseline risk features and the response assessment. For the future, maybe we will change our treatment algorithm. We will have the quadruplet eligible patients at baseline where we will start an induction therapy, and once we have sufficient data from trials that are ongoing and from large pooled analysis and retrospective analysis, maybe we can have an algorithm that can be a bit complex but can evaluate the risk-benefit profile or all the different factors for each patient in an attempt to have a more personalized approach. And this is for the near future. For a far future, I think that things may change. They are dynamically also in the treatment of myeloma, because the role of transplant probably When we will have the results of the large randomized trials that are using also immune therapy and that is challenging the transplant itself, may change again the role of transplantation in the era of quadruplet. And you can see here two of the large trials that are currently ongoing evaluating immune therapies in comparison with transplant. And this was my last slide, and with this I conclude, and I thank you all for the attention. Thank you.